Namaste, everyone, and a very, very warm welcome. Today, we're diving into a really important and sometimes tricky topic in pharmacology, antiarrhythmic drugs. You can think of these drugs as the conductors for your heart's own orchestra, making sure every single beat, every thuk-thuk is perfectly in time. So, let's get started. Just imagine for a second, your heart has its own personal drummer, right? Keeping that perfect steady beat day in and day out. But what happens if this drummer suddenly goes wild, starts playing way too fast, or too slow, or just completely offbeat? Well, that chaos is exactly the problem that we are going to tackle today. You see, when that beautiful, steady duck-duck rhythm of the heart becomes chaotic and irregular, we give it a name, arrhythmia. So in this session, we're going to explore the medicines that are designed to calm this chaos down and bring that rhythm right back in line. Now, to understand these pretty complex drugs, you need a good map, right? And our map for today is the absolutely brilliant Vaughan Williams classification. It's a lifesaver, trust me. It neatly organizes all these drugs into 4 main classes based on how they work, which makes the whole topic so much easier to remember. So let's kick things off with Class 1, the sodium channel blockers. Their main job, their whole purpose, is to target the fast sodium channels in the heart's muscle cells. Basically, they're telling those cells to just slow down a little bit during that electrical spark, the action potential that makes the heart contract. Now, Class I itself is cleverly broken down into 3 smaller groups, or subclasses, based on exactly how they affect that electrical signal. So you have Class IA drugs, like quinidine, which actually make the signal last longer. Then you have Class IB, with our friend lidocaine, which does the opposite, it shortens it. And finally, Class IC drugs, which are the most powerful of the lot, and they slow down the conduction of that signal quite a lot. Let's see what this means in practice. Okay, everyone pay close attention to this slide. This is a classic exam question. When you're comparing quinidine and procainamide, the key thing to remember is that quinidine has this alpha blocking action. This means it can cause a bigger drop in blood pressure, and it famously interacts with digoxin. Procainamide, on the other hand, well, it carries a different kind of risk. If you use it long-term, it can cause a lupus-like syndrome, something you have to watch out for. But, and this is a big but, with these drugs comes some really serious risks. With quinidine, you have to remember synchronism, that's ringing in the ears, and dizziness. And critically, both of these drugs can trigger a very dangerous arrhythmia called torsades de pointes. And like we just said, procainamide is linked to that drug-induced lupus. These are side effects you just cannot afford to forget. All right, now for Class IB, where we meet lidocaine. This one is the absolute star player in the ICU, the go-to drug for emergency ventricular arrhythmias. And its real genius is its selectivity. It's smart. It specifically targets the heart cells that are already damaged or ischemic, and it mostly leaves the healthy cells alone. How clever is that? So, some quick fire facts about lidocaine you need to know. First, it has to be given intravenously, by IV, because if you take it by mouth, the liver just breaks it all down. Second, its action is super fast and very short, maybe 10-20 minutes, which is perfect for emergencies. The main side effects are actually in the brain, neurological things like drowsiness or even seizures. But the best part? It's considered the least cardiotoxic of all the antiarrhythmics. And finally, to wrap up Class I, just a quick word on the IC drugs like propafenone and flecainide. Now, these are the heavy hitters, the most powerful sodium channel blockers we have. But that power comes with a really high risk of, get this, actually causing a new dangerous arrhythmia. This is a super important concept called proarrhythmia, and it's why these drugs are used very carefully. Okay, moving on. Let's now look at Class 2. And you probably know these guys very well, the beta blockers. Just think of them as the calming influence on a heart that's gotten all overexcited because of stress or exercise. So the crucial point, the main funda of beta blockers is this. They block the effects of adrenaline on the heart. That's it. So they are absolutely perfect for arrhythmias that are triggered by the body's fight or flight response, any kind of sympathetic stimulation. Propranolol is our classic example here. So what does it do? Well, it slows down the heart's natural pacemaker, the SA node, and, very importantly, it slows down conduction through the AV node, which is how we control a racing heart rate in conditions like atrial fibrillation. And here is a life-saving fact for you. Beta blockers are one of the few antiarrhythmics that are actually proven to reduce mortality in patients after they've had a heart attack. Next up is Class 3, the potassium channel blockers. Now, their main trick is to prolong the heart's recharging phase after each beat. By making each heartbeat last just a little bit longer, they give the heart tissue more time to rest and reset itself. And in Class 3, we have a true superstar, a real legend of a drug, amiodarone. I like to call it the jack of all trades because it doesn't just do one thing. Oh no, it does almost everything. So this is what makes amiodarone so special. Look at this. Its main job is Class 3 potassium channel blocking, sure, but it also acts like a Class 1 drug by blocking sodium channels, and a Class 2 drug with some beta blocking action, and even a Class 4 drug by weakly blocking calcium channels. It's this amazing multi-channel blocking that makes it so effective against so many different arrhythmias. However, a drug this powerful has to have a downside. And with long-term use, amiodarone is linked to some very serious and very unique side effects. We're talking about lung fibrosis, corneal deposits that can cause a headlight dazzle effect when driving at night, a weird bluish-gray skin discoloration, and major effects on the thyroid gland, because the drug itself actually contains iodine. These are critical to remember for your exams and for your patients. Another important drug in Class 3 is sotalol. It's an interesting one because it's got both Class 3 potassium channel blocking properties and it's a non-selective beta blocker. So it's like two drugs in one. Its main drawback, though, and it's a big one, is a significant dose-dependent risk of causing torsades to points. And finally, we have arrived at our last stop on this journey, Class 4, the calcium channel blockers. As the name suggests, their primary action is on the slow calcium channels, which are especially important in the pacemaker cells of the heart. The main player here is verapamil, and its most crucial effect is on the AV node. What it does is, by blocking those calcium channels, it dramatically slows down the electrical signal as it tries to pass from the atria down to the ventricles, and that right there is the key to how we control the heart rate in certain arrhythmias. Now this is clinically vital. This is what you need to know on the wards. We use verapamil to stop attacks of a fast heart rhythm called PSVT and to control the rate in atrial fibrillation. But look at the contraindications. You must never, ever use it in a patient with WPW syndrome who has a wide QRS tachycardia, or in a patient who has recently been given a beta blocker. And it is a huge no-no for ventricular tachycardia. It could be fatal. Please remember this. Okay, we've made it through all 4 classes. Phew, I know that was a lot of information. But now for the most important part. How do we use all of this knowledge? How do we actually choose the right drug for the right patient? Let's try and put it all together. So here it is, all in one place. Think of this as your cheat sheet for clinical practice. So a patient comes in with an acute PSVT attack. You're going to reach for IV adenosine or verapamil. For dangerous ventricular tachycardia and an emergency, your go-to drugs are IV amiodarone or lidocaine. You see, this table connects all the theory we just learned to real-world, life-saving decisions. So I want to end with this one final thought. The great paradox of these powerful drugs is that the very same medicine that can stop a life-threatening arrhythmia can sometimes start a new one. That's the concept of proarrhythmia. As future doctors, that is a heavy, heavy responsibility to carry. So the question I leave you with is, are you ready for it? Thank you for joining me. Hello, students, and welcome. Today, we're going to discuss one of the most crucial topics in all of medicine, antimicrobial drugs. Now, these are the weapons we use to fight infections, but as we are going to see, this power, it comes with a very serious risk. So let's get into it. But before we begin, I want you to just imagine something, a chilling thought. What if the medicines we completely rely on for everything from a simple throat infection to a life-threatening disease, what if they just stopped working? Now, this isn't some science fiction movie plot. It is a very real threat that we must understand. So let's dive in. Before we even touch upon the dangers, we really have to appreciate why these drugs are considered a modern miracle. They are often called magic bullets, and for a very, very good reason. Now, this statement might seem like a bit of an exaggeration, but let me tell you, it's not. Just think about it for a second. Most medicines, what do? They just manage your symptoms. But antimicrobials, they are different. They are one of the very few drugs that can actually cure an infectious disease, completely remove it from your body. They truly changed the face of medicine. The real magic behind these drugs, the main funda, is a principle we call selective toxicity. The idea is simple but brilliant. Create a poison that only harms the invading microbe, the bacteria, while leaving our own body cells completely untouched. It's like a sniper, you see, precisely targeting the enemy without causing any collateral damage to the host. The journey to find these drugs, it's an incredible story. It started way back in 1909 with the first so-called chemotherapy. Then things started moving faster with the discovery of sulfa drugs in the 30s. But the real game changer, the revolution, was penicillin in 1941. And after that, an amazing discovery that powerful antibiotics like streptomycin could be found right there in the soil beneath our feet. It was a true golden age of discovery. So, with all these new discoveries, doctors suddenly had an entire arsenal of weapons against infection. But to use them effectively, they needed a way to organize them, to classify them. You can't just pick one randomly, right? One of the simplest ways to classify these drugs is by what they actually do to the bacteria. Some are bacteriostatic. They basically hit the pause button. They stop the bacteria from growing and multiplying, which gives our own immune system a chance to catch up and clear the infection. Others, though, are bactericidal. They don't just pause the threat. No, they go straight for the kill. They destroy the bacteria directly. So, how do these drugs actually work? What are their attack strategies on this microscopic battlefield that is happening inside our bodies? This is where it gets really clever. The absolutely crucial point here is that bacterial cells are very different from our own human cells. They have unique structures, unique processes that our cells just don't have. Antimicrobial drugs are brilliantly designed to exploit exactly those differences. That is the key to their selective attack. You can think of these mechanisms almost like military strategies, you know? Some drugs, they just blast through the bacterium's outer defenses, its cell wall. Others are more sneaky. They sabotage its internal factories so it can't build the proteins it needs to survive. Some corrupt its genetic blueprints, the DNA, while others cut off its essential supply lines. And here you can see those strategies laid out in more technical terms. Things like inhibiting cell wall synthesis, well, that's how drugs like penicillin break down the bacteria's defenses. Others, like inhibiting protein synthesis, are basically shutting down their factories. The key takeaway, students, is that each class of drug targets a very specific vulnerability in the microbe. It's highly targeted. But, and this is a very important but, this incredible power comes with a great risk. The very effectiveness of these drugs can lead to significant problems, especially when they are misused or overused, which happens all the time. We're going to focus on the two biggest dangers that have come from our reliance on these amazing drugs. First, drug resistance, and second, a phenomenon called superinfection. The first major danger is acquired resistance. Now, this is not about bacteria that were always immune to a drug from the start. No, this is about bacteria evolving, learning how to fight back and survive an attack that used to be lethal. And let me tell you, this has become a massive, massive clinical problem worldwide. So how does this happen? Well, it's basically evolution in fast forward. In any large population of bacteria, just by random chance, a few will be naturally a little bit tougher. When we introduce an antibiotic, it kills off all the weak, vulnerable bacteria. But who survives? The resistant ones. And with all their competition suddenly gone, they are free to multiply and take over. Soon, the entire infection is made up of these superbugs. Our use of the drug actually creates the perfect environment for them to thrive. This second major problem is something called a superinfection. Think of the normal microbes in your gut as a balanced, healthy garden. A broad-spectrum antibiotic is like a bomb dropped on that garden. It kills the bad weeds, yes, but it also kills many of the good plants. This creates an opening, a vacuum, for a very tough, drug-resistant organism to come in and take over, causing a brand new and often worse infection on top of the old one. And this is especially dangerous for patients whose own immune systems are already weak. People with conditions like AIDS or cancer, those on steroids, or even very elderly people. They are at a much higher risk of developing these very difficult-to-treat superinfections. The situation is clearly very serious, but it is not hopeless. The solution lies in our collective responsibility, everyone's responsibility, to use these precious medicines wisely. This brings us to the most important question of all. What can we do as doctors, as patients, as a society to prevent this frightening future where our magic bullets no longer work? The principles are quite straightforward. First, we have to stop using antibiotics indiscriminately for things like the common cold, which is caused by a virus. It's useless. When an antibiotic is necessary, it's crucial that it's the right one at the right dose and for the full course of treatment. This means using more targeted, narrow-spectrum drugs instead of the big bombs whenever possible. This simple step helps slow down the spread of resistance. So I will leave you with this final, provocative question. The miracle of antibiotics transformed the 20th century. Whether we enter a post-antibiotic era in the 21st, well, that is not inevitable. It's a choice. And it is a choice that rests in all of our hands.